Good afternoon, everyone. I hope you're all staying safe and healthy. My name is Deanna Fenton, Program Manager here at the Alliance, and it's my pleasure to welcome you to today's program, which will highlight strategies for reducing coordinator turnover and improving productivity. Now, before we go ahead and get started, I'd like to mention a few quick notes and reminders for all of you as participants in today's program. When accessing our webinars, it's highly recommended that you use the Chrome browser to ensure an optimal visual and audio experience. If you're already using Chrome and experience any audio issues, we recommend reconnecting to the webinar using the phone number that was provided in your confirmation email. Should you need any assistance, please feel free to contact a member from the Alliance team. Additionally, throughout the course of today's presentation, your audio lines will remain muted. This is to ensure the best audio quality for our speakers. That said, we ask that you take note of the chat feature that's located in the bottom left-hand corner of your screen. This chat will be used to pose questions to our presenters during the Q&A discussion, so if you have any questions that come up during the course of the webinar, please feel free to submit them at any time. Once the presentation has concluded, we'll go ahead and transition into our Q&A discussion, where our presenters will address as many of your questions as time allows. Now, for anyone interested in our upcoming webinars, please note registration is currently open for our next Get Connected webinar, which will focus on strategies for maintaining timely referrals amidst the pandemic. You can join us for that on September 8th at 2 p.m. Eastern. Registration is also open for our next transplant-focused webinar, which will highlight medical marijuana and CBD oil use pre- and post-transplant. Be sure to join us for that on September 24th at 3 p.m. Eastern. For more information on all of our upcoming webinars and to ensure you have the latest information, please visit our website at organdonationalliance.org. Now, following the conclusion of today's program, you will all be eligible to claim continuing education credits. For this webinar, we are offering 1 Step-C credit and 1 nursing contact hour for your participation. Additionally, a certificate of attendance will be made available for those of you seeking CEs that are not being offered. Prior to receiving your credits and certificates, you'll be asked to complete a brief online evaluation that will allow you the opportunity to provide us with your valuable feedback. If you're listening in a group, please be sure to get the evaluation email from your group lead. As a friendly reminder, you'll have 30 calendar days to complete your evaluations and claim your credit. Now, without further ado, I'd like to go ahead and begin today's program by introducing our moderator, our very own Belinda Jones, Program Consultant here at the Alliance. Belinda, as always, it's a pleasure to have you with us, and at this point, I'll go ahead and turn it over to you to introduce both of our speakers.
Thank you, Deanna. It's my pleasure to introduce our speakers for today. We have Ginny McBride and Barry Friedman. Ginny McBride, RN MPH, is the Executive Director of Our Legacy Organ and Tissue Donation Services. She entered the organ donation community of practice in 1987 at the Gift of Life Donor Program in Philadelphia, and in 1990 became Director of Recovery Services at Louisiana Organ Procurement Agency. Subsequently, as a public health analyst at the United States Department of Health and Human Services, Health Resources and Services Administration, Division of Transplantation. She has spent time as a Division of Transplantation, was notable for helping create the Breakthrough Collaborative Initiatives and Projects Officer for HRSA's contract with UNOS to operate the Organ Procurement and Transplantation Network, or OPTN. She became Executive Director of Our Legacy in June of 2017. Barry Friedman attended Southern Illinois University and graduated with a bachelor's in nursing and an MBA with a minor in healthcare administration. Mr. Friedman currently serves as the Executive Director of Advent Health Transplant Institute and has been an active member of the transplant community. He is a member of AST. He's a past president of NATCO and has served on a variety of committees, including the Board of Directors for the OPTN and UNOS. He currently serves as the chair of the Ad Hoc International Relations Committee. Mr. Friedman has authored and co-authored several articles and has organized and participated in several local and national and international transplant conferences. He has been a dedicated member of the transplant community and continues to lead the advancement of transplantation for well over 3 decades. So at this point, I will turn the program over to Ginny and Barry.
Thank you, Belinda. It's a pleasure to have the opportunity to be here with you all today. And I think what we've learned already is that you have 2 dinosaurs speaking with you today. And I think that is an important message, that there are people who come into this field and it captures us and we stay here for a long time. And so I think it's great to have the opportunity to talk about how to capture the hearts of more people and how to help them stay with us for a long time. I think the other thing that Belinda didn't mention, although she probably doesn't know it, is that Barry and I both work in Orlando, Florida. Barry is the director of the Transplant Institute at Advent Health Orlando Hospital, and my OPO, our legacy, is a hospital-based OPO based at Advent Health. So when I speak to you today about the journeys that I'm going to share with you, I think it's good for you to know that Barry watched the whole thing happen. And so I may turn to Barry at certain points and, just get his sense of what was happening and what he was seeing and experiencing as we were going through our journey. So again, I'm really happy to be here with you today. So managing burnout during periods of growth is what I'm going to talk about, because it's really what happened to our legacy. And I'll show you some data in a couple seconds. But first, I wanted you to see that our OPO is based, as I said, in Orlando, Florida. Our population base is 4.2 million people, and we serve 2 transplant centers, Advent Health Orlando and Halifax Health in Daytona Beach. And we serve 38 acute care hospitals in our 10-county service area. So as OPOs go, we're rather small. We have a staff of about 60 full and per diem employees. And but we have a lot of deaths in our service area. We may be one of the smallest OPOs, but we are ranked 8th in terms of the number of deaths in our service area. So we are a busy OPO, and we became busier over the last few years. So the story that I'm going to tell you today is really a story about building and about foundation and about continuing to improve the work that you're putting together and that you're constructing. And so, of course, as I was thinking about this notion of building, my favorite architect came to mind, Frank Lloyd Wright. So I started to Google around a little bit to see what Frank Lloyd Wright had to say about building. And I love this first quote: "I know the price of success, dedication, hard work, and an unremitting devotion to the things you want to see happen." And I thought that that was so illustrative of the journey that we've been on at our legacy. And if any of you are Frank Lloyd Wright fans, here's my favorite Frank Lloyd Wright house. This is Falling Water in Mill Run, Pennsylvania. I got to go there last summer for the first time, and if you've never been, it's a religious experience. Please go. It's your soul will be touched. So I kind of debated whether I should put this at the beginning or at the end, because kind of I feel like what I'm telling you is the end of our story, but I think really in truth this is the catalyst of our story. You can see that for several years, beginning around 2010, our legacy was performing at about 100 organ donors annually, and in fact in 2014 decreased to 87 donors. Since then, you can see that we've enjoyed a lot of success over subsequent years in terms of the number of organ donors in our service area, and the number for 2020 is actually annualized. So this is me as an executive director being optimistic that the first 6 years or the first 6 months of this year will be the same as the last 6 months, and I surely do hope so, because it will be the first time we go over 200 donors in a year, which means that we've doubled donation over the last 10 years, which I think is something any OPO can be justifiably proud about. And then here is the number of organs that we've transplanted, and the story is quite similar. We crossed the 600 organ threshold in 2019 for the first time and hope to be able to do that again. And this is certainly cause for celebration, but I think it also certainly has its impact. I'm just seeing a note in the chat that someone can't hear me, so I'm going to turn it up and hope that that's better. So this is the sum of our journey, and I think what I'd like to talk to you about for the rest of my time with you is how we dealt with it. Because growth, as you all know, is not it's not a neutral thing. Growth has its implications on OPOs, and we certainly saw that during the Organ Donation Breakthrough Collaborative, when some OPOs were starting to experience some significant success, but it stressed them significantly in terms of the need for resources and in terms of their staff's ability to handle it. And our legacy really is no different in that journey. I've indicated with a lightning bolt the number of times that the OPO executive director changed at our legacy since 2010, probably 2009, when a new executive director entered her position. And then the executive director changed in 2015 when the current executive director changed. So a new executive director came in, and I believe I'm correct that it was the first time that somebody from outside of our legacy became the executive director. And that proved to be a very fortuitous change for the organization, because what that new executive director did was to be very, very deliberate about bringing organ donation best practices into the organization and bringing a mentality of recovering organs for every transplant center in the country, not just the local transplant centers. So it was a big cultural shift. It was a big activity shift. And as you can see, in 2015, from 2015 to 2016 was probably the biggest year of growth for our legacy. And we've been able to maintain that level of performance, but also continue to improve upon it. So that's a big change for any organization, whether you work for an OPO or a transplant center. When your senior transplant administrator changes, or when your OPO executive director changes, that is a stressor for everybody who works at the organization, because there could potentially be a vacuum of leadership for a period of time, which there was for our legacy. In my case, the position was vacated by the previous director in December of 2016, I believe, and I did not arrive until June of 2017. And interestingly, there was no person under me. There was no director of organ recovery under me. So at least for the clinical team, other than the medical director who's been with us for 40 years, but from the day-to-day perspective of managing donors and running the organization and someone trying to be in charge, there really was no one in charge. So this staff held the organization together for quite a long time. But that also presented some challenges, because what they were doing to hold the organization together may not necessarily have been in the best interest of donation and donation cases. So that kind of turned into a situation that we'll talk about in a little bit. But those three transitions in a relatively short period of time, at least in the OPO world, 3 executive director changes in 10 years is kind of a lot. So, what were the impacts on the staff? And there were several, and I'm probably not including them all, or maybe I'm overstating some, but this is at least my opinion. So first of all, they were engaging in new and unfamiliar clinical situations and clinical direction. And by that I mean, maybe they were starting to be encouraged to do DCD cases with older donors, or older brain death cases, or more increased PHS high-risk cases, but things that were unfamiliar to them. There was more emphasis on lung recovery, more emphasis on managing donors for longer periods of time. All of these things that are relatively stable OPO best practices were still a little bit unfamiliar to our team. And so they weren't, like how change is. Some people love change and some people don't love change. So it was really challenging, I think, for the staff to decide whether or not they could become accustomed to this new reality. The other new reality is they were doing, at least 75% more donors than they were used to. So you can imagine when you're used to maybe doing 2 or 3 donation cases a month, and all of a sudden now you're doing 10 or 11 or 12, that changes your perceptions of your job. It changes the time that you have for your family. It changes your perception of whether or not this is something you want to keep doing. And I think you all know, certainly whether you work at a transplant center or an OPO, that it takes a long time to train a transplant coordinator. So, when you've gotten them to the point where they've been there for 2 years and they're just kind of figuring out how to do the job and how to work collaboratively with our donor hospital staff and how to be comfortable with the transplant surgeons, it's difficult to have them leaving because now you have to start again, and that's really very challenging. And so we found that people who were suddenly in this situation of more work than they expected or were used to really felt like it was time for them to leave and, to be able to do a job that would either allow them to go to school or would allow them to be with their families. And for those who stayed behind, there was really a certain level of dissatisfaction about all the changes that were coming at them. And this was just my first 6 months. I mean, we didn't even have a new clinical director yet, but we had to keep the organization going forward, and we couldn't lose the gains that we had already accumulated. So it was really hard for them to be reporting to the executive director. It was hard for me to be the one that the coordinators were reporting to, because I hadn't been at the clinical bedside, the donor bedside, for 15 years or so. So it was, everybody was just trying to figure out how to get through the day sometimes. And that certainly and legitimately took its toll on the staff. And so we lost a fair number of people early on, and people that we hoped would stay for the long haul but just felt like they couldn't. So what to do is really the question. And for us, the answer was you just have to keep building. You have to keep figuring out a way to create a sound infrastructure in the organization so that people could start to feel safe staying. Here's a great safe place. If you've ever been to Scottsdale, Arizona, you may have gone to Taliesin West, which is one of Frank Lloyd Wright's most famous houses. And it's a great place when you're in the middle of all of this pandemonium that is your job. To be able to look at something serene is really a good thing. But you have to go wholeheartedly into anything in order to achieve anything worth having. And I think that's a good segue into the actions that we took to help stabilize the organization and help bring some certainty to our staff. And so we took what I call a bottom-up and a top-down approach. And what I mean by that is that if we were going to create stability in the organization, if we wanted to create buy-in among the staff to stay and to learn and continue to grow and to continue to help us capitalize on this exciting growth that we were experiencing, we had to all work on ourselves. And that meant the staff. We had to work on things we could do to support the staff. But as a leadership team, we also had to work on ourselves. And we had to recognize that we were experiencing stress as well. And how were we going to handle that and deal with it so that we were mentally prepared and present to help the staff get to where they needed to be. So really what happened is listed here in these 8 bullet points. And the things that we focused on the staff was first and foremost to get the right leader. The organ procurement coordinators needed somebody that they could call their own, who was their champion, who knew their job, who could do their job, who could model their job the way it needed to be done, who could help them create the right mental philosophy to be able to understand what their goals and objectives were. And we were able to hire a wonderful leader, a very experienced manager from New England Donor Services. Her name was Laura Huckstein. Her name still is Laura Huckstein. And Laura kind of took the challenge and started to lead this team of 10 OPCs at the time, which brings me to the next point. As you're growing the number of donors, you have to address it by doing a corresponding increase in the number of staff. And my predecessor had started to do that, but growth was occurring so rapidly that we had to work very closely with our hospital vice president to help her understand what it was that was happening. And quite honestly, we had to help her understand the financial ramifications of what was happening when we lost donors, or that we couldn't be available to recover donors or recover enough organs from donors. So when she was able to understand why increasing donors was so important to the OPO and our ability to work collaboratively with the transplant center, it became easier for her to understand why staffing had to be addressed. So we were able to increase by 2 the number of organ procurement coordinators that we had, and so that brought us up to our current, or at the previously high level of 12 OPCs. But because of Laura's experience, we also, and because of dialogue with the coordinators, and I think that's an important thing to emphasize, is that throughout all of this change, Laura did a fantastic job of hearing the concerns of the organ procurement coordinators and including that feedback and that information into an improvement plan. And a big part of the improvement plan was to figure out, did the nurses have to go out on every case? Did it always have to be a critical care nurse who was making the first response to families or to the hospital? We're very lucky at our legacy that we have a great clinical trigger, a GCS of 5, and that gives us access to patients earlier than I think some OPOs have. So we can actually go into our electronic health records. We have access to every hospital that we have. And we didn't need nurses to do that. We could use paramedics to do that. We could use the clinical first responders who are our paramedics. We could use them to go to the hospitals to make that first contact, to figure out what was happening, to do the deep chart review, to get to know the doctors and nurses so that we could begin to make decisions about where we needed to deploy the critical care nurses, because their expertise was, necessary in a very specific portfolio of our work. And by that I mean when we were getting to the point where a patient was about to be pronounced brain dead or withdrawal of life support decisions were about to be made, that was when we wanted to start deploying the nurses. Up until that point, the clinical first responders were starting to do a beautiful job working with our hospital teams and getting us to the point where final end-of-life decisions were being made, and that's when the nurses stepped in, and that's when the family services coordinators stepped in. And we were also short on those, and that's a journey that's taken us a little bit longer. So I think the point is that we have been able over the past few years to take a good hard look at who were the best people to do certain tasks and how to diversify the staff so that we were using the right people at the right time. And obviously, paramedics are less costly than critical care nurses, so we could actually hire more of them and have a huge positive impact on our team. So I really commend Laura and all of our nurses who kind of made that assessment that changing up who was the first responder to the hospital was a good thing to do. And that took a lot of the pressure off of our nurses and helped them be able to focus on what they did best. Another thing that was important is that Laura really did a great job of developing consistent decision-making about the direction of the program and about what types of cases we were going to follow and respond to. And that enabled the team to start getting a better sense of when and why we became involved in donation situations. Because, before that, I think a lot of individual coordinators were kind of making the decisions, and they didn't always agree with one another. So having that one consistent clinical leader was very important. The other thing that Laura excels at and I am terrible at, is having fun along the way. I'm a really mission-driven person. My head is always down. I'm always, looking in my computer. And that's good for some things, but it's not very helpful to help people feel appreciated. And that is one of the things that Laura did beautifully. So if you have people on your team, if you have managers on your team who are good at that, celebrate it. It is so incredibly important. And I've learned a lot about the value of appreciation and the value of recognizing people for a job well done in ways that are, fun and entertaining. And, we live near Disney World, so, I can tell you there have been some visits to Disney by members of our team. There have been visits to SeaWorld. There have been visits to the beach. We have the beaches an hour away. So we have definitely taken the opportunity to let our hair down, let off some steam, and get to know each other as people, because that is also a really important component of helping people understand that they have somewhere that they can go if they need to let off a little steam, so that they can get mentally prepared to go back into the fray and have some emotional reserve left to help them, be part of their families and keep doing this incredible job. I'm probably not talking about everything they've done along the way, but those are really some of the things that stand out for me about why it was important and why their growth was so important. And then the other important thing is leadership focus. That old saying that people don't leave their jobs, they leave their bosses. And so we took that very seriously. And one of the good things about being a hospital-based OPO, and I think for many of you that work at transplant hospitals, especially academic institutions, you probably have access to some of these resources, and maybe you haven't explored them. But there are great opportunities to identify people who are coaches, who are mentors, who are psychologists, who can be an asset to your team. And so I was able to get a coach that I worked with over probably an 8-month period of time, helping me with a 360-degree review, giving me insights into my strengths and weaknesses and things about me that I could use to my advantage to help the staff. And that was really eye-opening for me. I tend to be an introvert, so I just, like I said, I put my head down and work. But to have somebody come in and sit down and talk to you about, hey, these are your strengths. These are things that you could leverage to help work with your team. And it was just the most amazing thing for me. And we've been able to do some things with our management team as a whole to help them function better as a team so that they could more consistently lead and demonstrate the values and model the behaviors of teamwork for their own teams. And so that was really important, that we be perceived as a leadership team. So I think, so what was the effect of this? And I showed you the increase in numbers, but I also wanted you to see that for the clinical team, this is what's been going on over the last year or so, the last 13 months. Our percentage of turnover among our clinical team has dropped. And unfortunately, this is our new financial tracking system. So we switched it last year, and so we can't see some of the higher rates of turnover, which were actually up into the 20% range. So this has really improved over the last year and a half to 2 years. And we're really proud of this. And I think that the attention and devotion to leadership issues within our management team has very much helped to stabilize the staff, and we pay more attention to hearing feedback and input from the frontline teams. And I think that's helped us a lot, help people feel valued and help people feel that their feedback matters and help them be able to build a work environment that works best for them. And so finally, I feel like we are in a place of building something beautiful, and we will continue to be able to do that with our leadership team and building on our strategic plan and assessing where our journey will take us going forward. This is the Guggenheim Museum in New York City, a tribute to my colleagues in New York, if there are any on the call. So I think that thinking about your work and how to build your teams and how to create environments where burnout is the last option instead of the first option is really important. So I thank you for your time, and I'm happy to answer any questions when Barry's presentation is done. And Barry, if you have anything you want to add to what I've said, any truths that I have not given adequate transparency to, then I turn it over to you.
Thank you, Jenny. I agree with everything except about being a dinosaur. I still feel like I'm in my infancy as we work collaboratively together. Thank you, Jenny.
You're awesome.
So I want to talk to you today a little bit from the clinical side, from burnout to breakthroughs. And originally, Angie Corson was supposed to give this talk, and she had an emergency come up. So I worked collaboratively with Angie because she put a lot of work into this presentation. Angie has led transplant programs out of New York, Iowa, and now in Arizona. So I want to thank Angie, and I wish her the best with her emergency. Both Jenny and I, one of our strengths that Jenny and I bring to the profession is we both started in the field at the bedside, both in critical care. We're amazed at what organ donors and how recipients were treated at the bedside. But then both of us went into the field of organ procurement. And I took the path of going on the clinical side, where Jenny continued in the field of organ procurement. So what I want to talk about is some strategies to work to reduce coordinator turnover and improve productivity from a clinical side. One thing I've learned over the years, and I don't know if we have any physicians on this call or surgeons, but the transplant coordinator is a critical team member. And for those of you on the clinical side of the house, I think even the toughest of transplant surgeons or transplant physicians will admit that a transplant coordinator is probably one of the core pivotal people within their organization. It's difficult to recruit transplant coordinators as a whole. Many of us come from transplant units, either on the inpatient or on the outpatient side. And depending on where you're from, if you're more in a rural area, it's harder to recruit than from a larger urban area. The state of Florida, if you look, we have every name brand transplant center in the state of Florida. However, because of our population, when I look at my colleagues that do transplants in the state of Florida, we work very collaboratively. That's one thing you'll find about, and I think needs to be really brought forward more often, is that we're not competitive in ways, but we need to be acting more collegial as a transplant profession. So whenever I have challenges, I feel very comfortable reaching out to other transplant administrators in the state of Florida or throughout the United States or even internationally. And the same thing for frontline coordinators, and that's what Angie and I focused our talk on today, is about the frontline coordinator. The job is very interesting. It has a lot of attractions to it. It's very autonomous in a lot of ways. You develop a relationship with a patient at probably one of their most challenging times of their lives. The providers that are referring these patients to us, it's really end-stage organ failure that our pre-transplant coordinators work with on the clinical side. I think in the future you'll see our jobs potentially even changing more, in that we become that pre-transplant, pre-end-stage organ failure healthcare provider, nurse, or whatever profession you're in as a coordinator, that helps to guide the right channel along with our physician partners. Turnover rate is really multifactorial and varies from program to program. If you look around the United States, for those of us that are committed to our profession, not committed to any mental health areas that need help, but we're really committed to our programs. And people stay for a very long time, or if they're recruited usually by a provider that might have moved to another center as well. So what is adequate staffing? What's the right level for our caseload? That's the challenge that I know I have, my executive leaders at our healthcare facility have. I oversee our program here in Orlando. Advent Health has a transplant program in Denver, Colorado. I work with our program there as well. But what are some of the opportunities we have to determine, do we have the right staffing? Everybody always says, I need more help, but how can we really show that we need more help? Well, one of the tools that are out there, UNOS actually has a staffing survey, and if I don't know many of you that are on this call today listening, but your transplant administrator should be able to go in there and look and try to do comparison by region of where you are, by volume of transplants that you do with like transplant centers, and it tells you how many transplant coordinators you should have, how many physicians, how many surgeons, how many social workers. I have tried that approach, and I will tell you a lot of veteran C-suite, COOs, CEOs, CFOs, they don't buy it. They feel like we're just putting our numbers in there so that we can increase staff. So over the years, I've worked with my C-suite folks, and we've developed what I call trigger methodologies. So we agree upon at a set number of patients, we use patients as an indicator, how long it takes to get a patient in for evaluation, how long they're on the wait list, after the transplant, how long they're inpatient, how many inpatient visits, how we've moved inpatient now to outpatient infusion procedure centers within the transplant programs. So we try to really develop our staffing based on factual information versus gut, heart, and how many hours per day that we're working. I would say, unfortunately, we still don't have a standardized approach. What is the difference between pre and post? Pre-kidney is very different from pre-liver, which is very different from pre-heart, which is very different from pre-lung. I'm blessed at Advent Health that I have a transplant institute, and we have a staff of about 150 people that are nurse coordinators, transplant assistants, financial coordinators, social workers, dietitians, physicians, surgeons. And initially, when you heard in my bio something that was left out, and I intentionally left it out, was that I'm also a retired Air Force. I was a major. I did 2 tours in Iraq in 2003. I set up the aeromedical airlift in 2003 for the invasion into Iraq. And one thing I learned is that what is the magic number to make things work? How much staff do you need to really make the difference? And the one thing I would say is that staff members, we always want people doing the right person, right job. So do nurses really need to be doing things that a transplant assistant can do, or something that a physician should be doing, or an advanced practitioner? So one of the walkaways today is, I would say, right person, right job. Look at what the skill set is of the coordinator, and are they really doing the right core competencies? And again, you have good information if you choose to look at your NATCO core competencies. Also, experienced coordinators versus new coordinators. People have said that is 150 post-transplant patients the right volume for a liver program, but really is it 300 to 500 patients if you're a kidney coordinator? Those are all challenges we face every day. Work environment can be a challenge and will vary from program to program. I can tell you that when the COVID-19 pandemic struck and I was given guidance by our administration that I needed staff working from home, it was very challenging for me. And the one thing I will say that, again, drawing on my military experience, not only did I now have to protect my patient, but I now had to protect my staff as well. If I didn't have staff that were healthy and I saw what was going on with my colleagues in New York and Pennsylvania and California, where the initial COVID struck the hardest, if my staff wasn't well, we couldn't do our job as transplant. And if you remember, transplant was indicated as a life-saving procedure, so we never shut down during the COVID pandemic, or as it's going on now. We continue not to shut down, and we ensure that we update our playbook so that we can ensure our patients are being taken care of properly by our staff, and our physicians are able to provide their services as well, and the collaboration we have with our organ procurement agency. So what is the relationship that we have? What's the environment? Our physicians, another piece of useful information that I think is helpful for you that I've learned over the years as an administrator is patients don't come to your facility because you've got good parking or great beds or the food is great. They're coming there because there's a provider that can help them. And when I say provider, it's a team of people. It's not just the surgeon or the medical physician, but a core pivotal person is the nurse transplant coordinator. The other piece I'll say is you need to, again, look at what does the coordinator's responsibility include? Does it include just coordinating transplants? Does it include the management of patients that are sick while they're on the wait list or while they're inpatient or after the transplant? Coordinator itself is a challenging job because it's the central hub of the transplant program. If you ask any patient, any provider, again, they will say it's the transplant coordinator. Programs don't function without transplant coordinators. As a matter of fact, there are regulatory requirements, and it's, again, a learning point here. If your administrator says, I want a transplant coordinator, but I still want them, doing their job of something else that's non-transplant, there are very strict regulatory requirements from CMS, from the OPTN UNOS, that really need to be driven in. It's not something that you should use as an excuse, but it is a requirement. What support staff is there to assist coordinators and handle things that don't require an RN license? I can tell you a transplant administrative assistant is worth their weight in gold. And if you can get a transplant coordinator, and especially a seasoned transplant coordinator that understands how to lead a team of transplant professionals, schedulers, assistants, administrative people, social workers, dietitians, it really creates a better functioning program, and it also makes the transplant coordinator's job, I think, help to create more retainability of your transplant coordinator. What is the right nursing license? I have seen a growth in advanced practitioners in the field of nursing, where most transplant coordinators come from on the clinical side, and maybe that's right for your program. Maybe an advanced practitioner is the right level of job entry, but there's certainly bachelor's prepared nurses that do an excellent job, or even there's still a cadre of folks that are AD nurses as well without bachelor's degrees, so associate degrees. What organizational systems are in place to support efficient processes? And that's critical, and that's where, again, your administrator with C-suite and staff really need to develop that. One size does not fit all process. So one walk away today, yes, I can give you information. Jenny gave you information from an OPO side of the house. But I will tell you, working collaboratively is extremely important. Our center recently started doing DCD hearts off the Transmedics. And when I set up the program, our Organ Procurement Organization, our legacy, was a critical part of the success of the transplant of that organ. And lessons learned were that I didn't have, a good amount of communication between our transplant coordinators and our surgeons and our Organ Procurement Organization when we started the program initially back in January. And we learned along the way, but because we had a good relationship, we were able to identify where those weaknesses were in the job, and we were able to come up with the right solution. We also have concerns about confidentiality of information, not wanting to report issues for fear of retaliation. And when you're working in transplant, most of us are type A individuals. We strive to work on in the excitement of the field, in the heat of the moment. The one thing I will tell you is, transplant, because we have people flying out, we have a playbook and we try to adhere to that playbook. But sometimes we have to go outside of that playbook. And what I always tell my staff is that if you have to go outside of the playbook, touch base with somebody on the team that's more senior than you to really walk through that. When I was in the military, I had a very simple process when I was overseas. I told my folks, we train to fight, but the one thing I want to see is you fight as you train and do not deviate from that, because that's what gets people in trouble. And I use that same motto here at our Transplant Institute, day in and day out. Collecting information should be a routine part of exit interviews when I do lose staff members, whether they're going to other transplant centers or they decide at this point in life with their family lifestyle it's not working out for them. I sit down with every staff member that's leaving, whether it's the receptionist who answers the phone or it's my senior rock star transplant surgeon. I sit down and I take that information, and then I also partner with our human resources folks to understand, why did I lose that person? What could have I done better? What could the organization have done better to help retain and then future recruits? Common concerns, compensation relative to job classification. Again, depending on the area of country that you live in will determine salaries. Many C-suite nursing directors, chief nursing officers, they feel the most important person is the nurse at the bedside, so compensation usually is directed that way. Many times transplant coordinators are treated as outpatient, Monday through Friday, 9 to 5 type individuals. But you really need to sit down with your C-suite and HR so that they understand that these are people that may be working, 3 24-hour shifts on call, and how do we compensate them appropriately. Another piece, and this has really been important for us during COVID-19, is that we have a lot of staff members working from home. Family members, their schools, shut down. So how do we ensure child care is being taken care of? Senior care that you have to do for those of you that are in that part of life where you have to take care of the seniors and your children. What's the ability to provide extra compensation based on specific projects or work that's occurring that's different? We need to be creative in our field. I think the ability to work remotely is being tested right now, and we're finding out that we can make this work. So the work environment really needs to be supportive of that and not toxic. And many times I'll hear, well, how come this person can work from home on this day, but I can't work from home? If you're a medical assistant and you need to see patients in the hospital, unfortunately I need you here in the hospital. Position classification, who do the coordinators report to? In my eyes, I've always worked in an environment where I have a senior transplant coordinator or a senior transplant manager who's more of a veteran in the field of their area of expertise. And it doesn't necessarily need to be in transplant. If their passion is in abdominal care and they have the right leadership skills, I think that is well suited. And here in my environment, I have a senior manager for our abdominal team, which includes adult and pediatric kidney, liver, pancreas transplants. We do not do intestinal, but we also have advanced liver disease for both adults and pediatrics. We don't do the dialysis here, so it's mainly for those patients that have end-stage renal failure that transplant is the option for either living donor or deceased donor, and then for pancreas transplant. Our heart program, I have a senior manager that oversees advanced heart failure, mechanical circulatory support, and transplant for heart. And then I also have a advanced lung disease and a lung transplant program, and they all report up to the same senior manager. I've also paired them with a physician leader for each of those. So we have two physician leaders. One of them is a transplant surgeon who represents both abdominal and cardiothoracic. He happens to be a abdominal transplant surgeon. And then I have a cardiologist that's overseeing the thoracic component for both heart and lung. They work in conjunction with myself and our senior managers. We also have a compliance manager, which again works very closely with our frontline coordinators to ensure that we're following regulatory requirements. We also have a practice manager for our clinic, along with a transplant manager that oversees day-to-day operations. We have a 24-room clinic with an 8-bed infusion procedure center. Another component, I have opinion on this, it's not based on fact, but coordinators can be either hourly or salaried. My recommendation is that we're a profession, and I believe transplant coordinators should be salaried. However, they need to be compensated for the work that they do. So if there's additional overtime that they're traditionally doing, and you can track that very closely, if they're having to be on call, those are all things that should affect their total package for compensation. And then I also try to reserve money for a bonus, sometimes quarterly, sometimes biannually or yearly, depending on if we hit the targets that we mutually agreed upon. And it's not always based on volume of transplants. It should be quality metrics that both you and your transplant coordinator agree on. Converting to salaries provide more budget stability, but it may reduce overall compensation for nurses if they've been doing a lot of overtime. On-call concerns. There's a wide variety from program to program about overtime. Many coordinators don't want to do that type of on-call pay. Some coordinators enjoy working from 6 p.m. to 6 a.m. I've seen that shift created now, where they're working usually on the pre-side and accepting organs. Some with advanced practitioners as coordinators taking sick calls all night and working in the inpatient area. But those are all things to help to create life-work balance, and that they're not creating life-work disruptions. Again, do they still need to come into work if they've had a busy night on call? And those are the trust relationships that our senior management team have with our frontline staff. Consider other options for on-call handling. I'm sure I'm not bringing something new to the table, but we could create internal call centers. You see some transplant programs that have dedicated staff that are accepting organs all night. They work in collaboration with their transplant physicians along with the nurse coordinators. There's outsourcing call duties. There's companies out there that you can contract with and pay a monthly fee for providing a wide variety of services. And this may be something that you want temporarily, or it may be permanent for your organization. And can you combine call between programs and reduce frequencies? Can the VAD coordinator and heart coordinator share call? Could a lung coordinator and a heart coordinator share call? Those are all things that are specific to your program, but I think it's helpful sometimes when you think outside the box. Creating flexible schedules are important. I've found that remote working, even before COVID, has been a good promoter for retaining staff. There has to be a great deal of coordination spent on the phone between primary coordinators and being able to interface with inpatient rounds. And can you accommodate to allow coordinators to work from home when emergencies come up, when a child is ill? Those are all important and build trust and longevity for your coordinators. Working remotely can create accommodation challenges. I know for me as an administrator, my goal now is I go around looking to see if lights are on phones that have people answered phone calls. But I think people can create logs to document the work that they're doing, and you as your administrators can work collaboratively to make sure we have check boxes to ensure that we're doing the job right and that patients feel the satisfaction. You'll also look to see what resources you have at your facility. We are very blessed. We have daycare centers that are discounted or free for some of our employees. So overall, there's no simple solution that fit all organizations and situations. One of the walkaways today from Jenny and my talk is that, depending on where you are in your growth cycle, and I was here when in 2015 for that growth cycle, it really changes how we do workload. And what's that trigger to say, now I need more staff? It's not just a gut feeling. It really is a well thought out process. Leaders need to be thoughtful about what issues they are. For those of you that are frontline staff on this call, working collaboratively with your leader to give factual information, not just because you've been up all night for 4 nights, may not be the enough factual information, but actually documenting and ensuring that you have the workflow that you want to adhere to. Being transparent about what may be feasible or not, that again, work on facts. Partnering with your human resources department is important. Transplant coordinators are not something they normally deal with, so educating your HR, educating your C-suite is important. The Alliance has a very good program to educate C-suite people. Include senior management. Really, they're not the enemy. They really want to work collaboratively with you. And then finally, flexibility is critical. Finally, when I first came on board in 2016, it really does take a village, and this is our entire Transplant Institute: heart, lung, liver, kidney, pancreas, our marketing people, our transplant assistants, transplant coordinators. This is what really makes it the success of a program. That's all I have. I know we don't have much time. I know I can stick around for a few minutes for questions. I'll turn it back over to my Alliance moderator.
Thank you, Barry. Thank you, Ginny, for a great presentation. We do have a couple of questions. The first one is from Leslie Sofarelli. I hope I'm saying that correctly. Her question is, has the shift schedule for clinical frontline staff been addressed? For example, changing the 24-hour call schedule to shorter shifts.
I'm not sure if that's for me or Barry, but I will say that our nurses still do take 24-hour shifts, but we have some of our coordinators who take night shifts. So even though someone might be on a 24-hour shift, the night nurse steps in and takes call if there's enough activity to permit relieving one of our 24-hour nurses. Our paramedics don't take 24-hour calls. They work 12-hour shifts. So we have some differences within the organization.
Okay, the same person had an observation that they wanted to share. Expanding the discipline to use for the clinical staff works. I heard you say using paramedics as first responders rather than a clinical coordinator RN is less costly. How about using the same paramedic, EMT, RT, or anyone with some sort of critical care background to do the job? Pay accordingly. Broaden the pool, diversify the medical backgrounds, adds depth to an OPO and different skill sets. Do you have a comment on that?
Yeah, I sure do, and that is our goal. We felt that having people in as paramedics first and giving them a chance to see and get used to the organ procurement coordinator job would help us identify who might be good at advancing. So I definitely agree, and I feel like our legacy is probably behind some of our OPO peers who have already done that well, but that is definitely a strategy for us going forward.
I see we are at the top of the hour, so Deanna, I will turn it back over to you to wrap us up.
All right, perfect. Thank you, Belinda. So it looks like to Belinda's point, we're going to go ahead and conclude the Q&A discussion. So I'd just like to say on behalf of the Alliance, a huge thank you to both Barry and Jenny for such a fantastic and what I think is a timely presentation. I think just based off the participation here we had today, you can tell that we had a very engaged crowd. So thank you so much for your efforts in putting together your presentations, and I thank you for joining us today. And to that effect, I'd also like to thank Belinda for taking the time to join us to facilitate today's discussion and moderate. So thank you, all three of you. And to our participants, as always, we thank you for your participation, and we hope to see you again on a future webinar. Enjoy the rest of your day, everyone.